Dear colleagues, dear parents, today I want to demonstrate a real-life monitoring in infants with severe heart failure due to congenital heart disease with the SOMNOtouch NIBP monitor that is feasible also in infants in an outpatient setting. Why do we need such a monitoring? Infant heart failure is the most frequent cause of death in pediatric cardiology. 20 years ago, the colleagues from Essen published their mortality data of the last years, and the death, of course, heart failure due to congenital heart defects is the most frequent cause of death in infants. In later life, the deaths are only some cases, and the death from cardiomyopathies are also less frequent than the deaths in infants with heart failure due to congenital heart disease. Looking to the recent data published in Circulation from the US, although there is a high mortality in infants, not only for severe congenital heart defect, but also for non-severe congenital heart disease. These infants have severe heart failure and don't reach the operation day. That's the reason because I decided to improve therapy of pediatric heart failure with the first beta blocker therapy in 1995. This is an 8-year-old girl, early postoperative with effusions after Fontan operation, who improved very good after beta blocker therapy. 1 year later, we used this therapy in infants, most of all with single ventricle and severe heart failure. And in 2000, we published the first prospective randomized beta blocker trial in infants with severe heart failure due to congenital heart disease with very good results. 2003, we performed the first propranolol therapy of an infant with multiple liver hemangioma. This is a very popular therapy today. And 2007, we performed the first prospective randomized beta blocker trial in patients after surgery of congenital heart defects. Looking to the publications in adults in gray and in children in red, there is the first publication of beta blocker therapy in heart failure by Finn Buckstein in 1975. There's a long discussion in adult cardiology until this therapy was recommended in the first guideline in 2000, and today is the most successful heart failure therapy. I published my data in infants 2 years earlier, but unfortunately, there is no increase of research to this topic in pediatric cardiology. Furthermore, I could demonstrate that heart failure in infancy is a very good early life stress model with high norepinephrine levels, most of all in infants with univentricular hearts and those with Down syndrome and congenital heart disease compared to preterms, although if they have a bad cause. In the same stress model, we could demonstrate a low vagus activity in these infants with univentricular hearts and Down syndrome and congenital heart defect that are lower than in preterm infants with cerebral palsy who have many complications. What we know today is that heart rate variability is a very good marker for risk stratification in infants with different disease compared to healthy infants. The heart rate variability parameter HF power that represents vagus activity is very low in infants with critical heart defects and improve after beta blocker therapy. Preterms, most of all those with lesser than 32 weeks have very low vagus activities. And in another study, the colleagues could demonstrate that those who develop necrotized enterocolitis have lower vagus activities compared to those infants who have no neck. Today, a recent publication in Circulation show that the SDNN and RMSSD heart rate variability parameters are very good for risk stratification in infants prior to surgery. This stress model and neurohormonal model was the base of our first treatment with beta blockers in 1995. We could demonstrate that tachypnea is related to heart rate, mean arterial pressure, and norepinephrine levels. And there's a complex interplay between hemodynamics, neurohormonal activation, and dysautonomia. I asked me in the last 30 years why we are not able to further investigate beta blocker therapy in infants with severe heart failure. My colleagues tell me that there are only a few patients who have this problem and the costs are too high to perform a trial. But if we look to the strategies in Germany to improve infant mortality, we are ready to spend nearly €500 million for RSV vaccination and meningococcal vaccination. And the data say that less than 40 infants died from these two infections in Germany. We have good prospective trials, and we have a recommendation from the STIKO. But if we look to the infants who died from heart failure, there are more than 200, and we have two candidates where propranolol is recommended in the guideline and propranolol is not recommended in the guideline. However, there's one study in infants with single ventricle who received enalapril in a prospective randomized trial, and the result is clearly negative. The infants didn't improve with the therapy. We have two trials with propranolol, our CHF pro-infant trial, and the Indian VSD-PHF trial. Both trials show a significant improvement after propranolol therapy. However, this therapy is not recommended in the guideline. For a better monitor, we need a monitor of oxygen saturation, we need a monitor of heart rate variability, and we further need a monitor of blood pressure. This study from the Human Genome Project show that the blood pressure increasing alleles improve survival in preterm infants, and the diastolic blood pressure alleles reduce risk of in-hospital mortality and time in ICU and hospital after CHD repair surgery. This data clearly show that those infants with higher blood pressure have a better survival after surgery of congenital heart disease. Moreover, the reduction of mortality risk is linked to the interaction between the increasing diastolic blood pressure alleles and the vasopressor dose. Obviously, we have a big problem with our guideline that recommend ACE inhibitors and vasodilators, and no prospective randomized trials show an improvement and benefit in infants with severe heart failure with these two drugs that are recommended by the guideline. I have shown in prospective trial that beta blockers de-escalate neurohormonal activation measured by norepinephrine and plasmarenin levels and improve dysautonomia measured by heart rate variability that have a massive improvement after propranolol therapy. In consequence, the clinical ROS score is significantly lower after propranolol therapy. However, the callings decide for the guideline therapy in Germany, and we must realize that after 2010, the mortality of congenital heart disease in Germany increased, and this is the reason of irrational heart failure therapy. To improve infant safety, we improve the monitoring of hemodynamic oxygen saturation and heart rate variability during medical therapy of these infants with severe heart failure. We have the possibility of a non-invasive continuous blood pressure monitoring using the pulse transit time. The SOMNOtouch NIBP monitor was used in children aged 5 to 17 years. You can see the data on the monitor. There's the blood pressure, the heart rate, and the saturation, and you can measure heart rate variability with this monitor. In a feasibility study published in Hearts 2025, we show the setting of the SOMNOtouch NIBP monitoring in infants. In older children, we have the situation with 3 electrodes for ECG and the pulse oximeter on the left finger. For babies, we used the toes to have a better artifact-free measurement of these data. The first case is an infant with hypoplastic left heart syndrome after Norwood 1 and Norwood 2 operation. There is in the lower line the very good analysis of oxygen saturation. The mean value is after Norwood 1 operation 74%. It's very low, of course, a small aorto-pulmonary shunt. After Norwood stage 2, the oxygen saturation increased to 81, and 2 months later to 83%. There are high fluctuations of the diastolic blood pressure indicated in pink, and this seems to be a life-threatening regulation during hypoxia. And after the improvement of saturation, the fluctuations disappeared in this infant. What about heart rate variability? These are the data after Norwood 1 operation, and there are the high frequency power values that indicates parasympathicus or vagus activity, and in yellow the low frequency power represents the sympathicus activation, and that's the leading of the HF power in this patient despite the very low values. And this baby is in a very good condition. The data clearly show that the diastolic and systolic blood pressure depends on saturation, and this seems to be regulated by heart rate variability. These are the correlation coefficients. The second patient is a baby after aorto-pulmonary shunt implantation in a tetralogy of Fallot, of course, hypoxic expels. The baby suffered from heart failure due to a pulmonary overcirculation with saturation of 89%. In this saturation, I use digoxin together with propranolol, and the saturation above 90% disappear and the baby is good. Again, we see the fluctuation of the diastolic blood pressure in pink that increase with lower saturation prior to corrective surgery. After corrective surgery, we have normal saturation of 97%, and the diastolic and systolic blood pressure are better and show now fluctuations. What about heart rate variability? In the first situation with propranolol therapy, the infant further suffer from heart failure, and the vagus activity in green is relatively low, and there's a struggle between vagus and sympathicus with no clearly dominance. After addition of digoxin with lower saturation, more and more the vagus increase and the baby improve. And after corrective surgery, the heart rate variabilities are higher. There's another axis, and we have very high high frequency pose and low frequency pose, like in healthy children. Again, there's a high correlation between blood pressure and heart rate variability. In this patient, the blood pressure seems to be regulated by the autonomic nervous system, indicated by heart rate variabilities. The university center prefer metoprolol instead of propranolol, and thus Norwood 2 patient with hypoplastic left heart syndrome. For further heart rate reduction, the baby received ivabradine, and there are very good vagus activities in green in this patient, and the patient is stable. We don't further use ivabradine. After termination of ivabradine therapy, there's no increase of heart rate. The blood pressure and saturations are stable, and we have very good high frequency and low frequency pairs in these patients who do not need further ivabradine therapy. Up to this patient with Down syndrome and complete atrioventricular septal defect, I had no experience with enalapril therapy in the last 20 years. The patient was treated by other colleagues, and the first visit of this patient at an age of 6 weeks show a cardiac decompensation by using enalapril, hydrochlorothiazide, and spironolactone. I had to admit the patient in the hospital, and the monitor measure the hemodynamic during the intensive care unit therapy. The baby get non-invasive ventilation and milrinone for treat his severe heart failure, and the vagus activity is very low in this situation, with higher low frequency values compared to high frequency values. After this therapy was changed to metoprolol and furosemide, the baby improved. Unfortunately, we have only the autoinitiator of this baby during metoprolol therapy, but there's a slight increase of vagus activity in green that is now in part higher than the low frequency power. The baby improved, and for the first time in his life, he had a weight gain. If the university hospital use metoprolol and I use propranolol within the last 25 years, I can compare the various activities during these two therapies, the propranolol data show significant higher vagus activities, except two patients who died later, and the clinical effect of metoprolol is good, but the vagus activities remain at a lower level compared to the propranolol data. That is the reason because I changed metoprolol to propranolol in two infants who further have severe heart failure. The first infant is a 10-month-old infant with pulmonary atresia after surgery, and there's severe heart failure with low vagus activities and low heart rate variability. After changing to propranolol, the fast Fourier analyzers show an improvement in heart rate variability, and the heart rates decrease and the baby is good. The second patient suffered from severe heart failure due to a truncus arteriosus communis with pulmonary overcirculation. He had no weight gain with metoprolol therapy. We changed to propranolol dioxin with an improvement of the fast Fourier analyzers. The NT-BNP values decrease, the high troponin T values decrease, and of course the weight gain. The baby reached 3.5 kilograms, and the surgeons accept for corrective surgery. After surgery, there is a further heart failure treated with propranolol and a steep increase of heart rate variabilities at the 75 days of life, and the baby is good in his further life. These are the two patients that I have demonstrated in this talk, and the first patient is a follow-up patient after shunt and corrective surgery. During the whole time he received propranolol with very low heart rate variabilities up to corrective surgery. The second patient is hypoplastic left heart syndrome after Norwood 1 and Norwood 2 operation, treated with metoprolol. And if I show in the later slides, the heart rate variabilities remains very low. As well, the fast Fourier analyzers and the RMSSD value. I try to explain the patient and colleagues this new approaches to children's medicine in this YouTube channel about heart failure, heart rate variability, COVID-19, and dysautonomia. And the heart failure talks are sometimes in English, for example, about the mortality of children with congenital heart disease, the preoperative therapy of heart failure in infants with congenital heart disease, the treatment of heart failure after surgery in older children, and the impact of dysautonomia on physical performance after surgery of congenital heart disease. I could demonstrate an improved catch-up growth in children treated with beta blockers compared to standard therapy, and all these data based on an early life stress model that seems to be very important for growth, cognition, and later cardiovascular risk. A summary was presented in this video about new approaches in diagnosis and therapy in diseases in childhood. Thank you for your attention.